My name is Kelly Germain.
To whom you are making the question?
To Dr. Zivadinov. You stated in the healthy controls that you had 48 familia controls and what, 150 non-familia. Now and you said there was really no difference at all. What do you mean by no difference as far as?
There was equal percentage of those people who had CCSVI in the familial group and who had CCSVI in the unfamilial group. The p-value was, if I correctly remember, 0.5, which pretty much the one is totally no difference. So something is becoming significant if it's less than 0.05, okay? And this was 0.859, which is like almost 50 times less p-value.
I'm Janine Hunt-Jackson, and my main question is there a way or a possibility of getting a copy of the slides that you presented today? Because I feel that a lot of things went through rather quickly, and I would personally like to take some time to go through.
So this guy near the camera already received the slides. His name is Jordan, and he will place on YouTube by hopefully tomorrow all the slides and all the presentation. It will be divided. It will be divided in 5 topics that we presented on: diagnosis, causality association, treatment, future research, and question and answers.
Yeah, my name is David Hunt Baker, and I'm a MS sufferer, first diagnosed in 1987. And a couple of quick comments and then a question. One comment is, I want to thank all 3 of you for the approach that you're taking. I don't know whether it was interested skepticism or excited skepticism approach, I think is really great to hear. So I want to thank all of you for dealing with that paradox. And going. The second quick comment I have is that as a patient, though I thank you for that, I have my patient views about things and want answers yesterday to these things. And one of the things that I think is important for you folks to keep in mind, I understand that blind studies are the Cadillac of how it's done, but really look at who needs to be blinded for the things that you're doing. I don't think I'm going to develop, ventricular problems based on whether I know I have it or not. So if you blind the doctor, that's great. If you blind the statistician, that's great. But to the extent you don't blind the patients, that really helps me out a lot, because I need to know what I need to worry about and what I don't need to worry about. So the more you can tell me, so I don't have to worry about what you're telling me, or whether it may be a cure or not, that really helps me out a lot. The question is, in terms of the vascular problems, have you noticed increased blood pressure as something that people have had as a way to maybe deal with things going on inside their veins? You increase the blood pressure to force the blood through as you try to get better, and is that something associated or not with it?
Thank you. There are a few different questions that you are asking there. I'll start off in the reverse order. So you talked about blood pressure. And one of the things that we are actively actually looking in our study is something that Dr. Zivadinov referred to, and that's perfusion. Perfusion means blood flowing to all individual parts of your brain. How well is it being perfused? And we're actually looking at perfusion in our patients. All patients, those treated and those not treated. So that is something that has been suggested in the past, that there may be a reduction in perfusion, so that even though MS is typically associated with MS plaques, which seem to be rather localized, Robert has shown in the past that the disease is much more globally affecting the brain than is assumed. So there is a global atrophy of the brain, global reduction of veins, and possibly global reduction in perfusion. So that's certainly possible. Although that's possible, I'm not quite sure physically how a blood pressure effect may necessarily affect a venous abnormality, but certainly it's all part of the same cascade, right? Blood's got to go in and it's got to come out. And if there's a reduction in the amount of outflow, there may be a compensatory increase in the inflow to compensate for that. So that's certainly an interesting hypothesis, but we don't know. Second thing that you alluded to earlier was blinding. So why is blinding important? Blinding is important because when you're assessing how well you're doing, sir, it determines the effect of treatment. So if you tell me that you're sleeping better, your energy is better, your temperature toleration is better, your attention span is better, well, that means a lot, because that means I score you as somebody who has benefited. And therefore, your perception is vital in establishing efficacy. And so, in fact, the most important person to blind is you.
Yeah, I only want to add on the blood pressure issue. As we all know, the blood pressure affects only the arteries. There's certain flow, mechanistic, and only there you have atherosclerosis. In veins, you don't have it. So it's clearly, and primarily because the pressure in the vein is much lower. So it's a lot of mechanistic, so veins are not directly, as much as we know today, related to blood pressure. But yes, it's all connected.
So these are some of the questions that we've received over the internet. And the big one is, why do a trial when people are already being treated and clearly being benefited in the many, many, many thousands all over the world? I mean, that's certainly the conclusion you would draw based on any assessment that you establish based on the internet and based on discussions. Well, the reason for that is that that therapy is really limited to the privileged few. Those who, and this is not presupposing the effectiveness of the treatment. Regardless of the effectiveness of the treatment, or even if you assume effectiveness of the treatment, that is limited to those privileged few who can fly across the globe to these few centers or within the United States where these services are being provided at a cost. And the cost is not being debated either. There's a cost to medical therapy. But the vast, vast, vast majority of MS patients are deprived of this therapy, deprived of it by their neurologists, deprived of this by their insurance carriers, by their hospital providers. And if you want to effect treatment that affects all of MS patients, benefits all of MS patients, you need to show effectiveness in something that can be reproduced by multiple organizations, so it benefits all of you, not just the select few. And that's the rationale for doing a trial, even though there is benefit being established, at least through common parlance and through internet chat rooms. That's not good enough to benefit you guys.
And just to add that our premise trial will not establish that it's a first step to show that other trials have to be done, which will be properly powered with hundreds of people, and where we will already provide steps how to blind people, how to, really answer on many pitfalls in doing such a trial. So, but I think that eventually positive data in our trial will definitely trigger many other people and scientists and researchers and funding organizations to begin consider such a treatment. And that's why we need to do things in a proper way. And I thank you, Adnan, for really putting this, because we need to be ensured that this treatment, if it's useful for MS patients, is not just given to those who are privileged because they are able, to get it.
I would like to add on only that our blinded study, if will be positive, we will provide treatment also for the placebo patient.
Absolutely. Another important question is that's also from internet, and that I would like Adnan, I would like to start and Adnan to continue, is what's the gold standard? It is critical that the patients with MS understand that if you go to some treatment place and you never had a screening before, that there is a very much higher chance that you are going to be told or you are going to be positive. I never heard or read on internet that there is no much shown or found in those people who, and clearly there is a huge discrepancy between what we are finding in our studies, right? And those which data are reported on internet. So there is a big mismatch here. And so in order to solve this mismatch, we definitely felt that beyond doing what is our expertise, which is the MRI, which is the Doppler, we definitely needed expertise of somebody who spent all his life of doing the invasive diagnostic. And that's Professor Siddiqui, who is also professor of radiology and not just of neurosurgery. And definitely this unique collaboration that we created, that in which we are blinded, and and I would like to acknowledge a couple of other people, especially Yuval Karmon and Krešimir Dolić, who are two fellows, one from Israel and one from Croatia, who helped us extremely much in interpreting these exams and did grow really of the work. And so clearly we need to understand what you see with intraluminal ultrasound and with catheter venography, and how will that match the screening test we are doing, because that's the only way to say what I'm doing with the Doppler is what you are going to find on invasive exam.
So gold standard really is a misnomer when you don't know what you're looking for. And that's why I have an objection to any one modality being purported as the way to do it, whether it's Doppler or transcranial Doppler or intravascular ultrasound or selective venography or MRV or CTV. These are all tools to look at veins in slightly different ways. And at this point, we are still in the information gathering phase to see, well, what do we see on each modality? And maybe 5 years down the road, we'll be able to say, well, you need a combination of A plus C to make a good diagnosis. And when you do those two tools, we find out that patients who have MS and have those two criteria are 80%, whereas healthy controls are only maybe 10%. And that would be a much stronger causality association. But at this point, there's no such thing as gold standard, and the more screening you can do, the better it is.